Good afternoon. On behalf of the School of Public Health, I'm really delighted to welcome all of you that are joining us here in person as well as those online to our inaugural lecture for our School of Public Health Grand Rounds. This lecture is organized by the Grand Rounds Planning Committee, which is chaired by Jelaine Arias, Associate Professor in the Department of Health Policy and Behavioral Sciences. Really want to thank the committee and Jelaine especially for organizing this event. The lecture engages nationally recognized thought leaders in dialogues that contribute to our school's mission to advance health equity and to foster solutions to contemporary and emerging health issues locally and around the globe. Today we're really honored to have Dr. Dayna Bowen Matthew, a leading voice in the national movement to illuminate and address racial inequities in healthcare, as our inaugural distinguished speaker. At this time, I want to invite Jelaine Arias to introduce Dr. Matthew.
So we are so excited to be here today from myself and the committee. I just want to say thank you so much for coming today. For us to start from a little bit of a vision and to see it come to reality is truly gratifying. I do want to take a moment, and not too much time, but just to really thank Marcus Cooper and as well as the other staff who single-handedly, I think, made this one of the easiest jobs ever to actually be able to pull something like this off. But really my job here today is to introduce our speaker, which if you're in this room, you likely already know her and know her work well. She is a nationally recognized lawyer and legal scholar with 3 decades of industry and academic experience. Dean Matthew is notably the first woman to lead GW Law. An expert in health equity and public health policy, she leads with passion and a drive towards public service. And she joined GW in 2020. Prior to that, she was on faculty at the University of Virginia School of Law, where she co-founded the UVA Equity Center, an interdisciplinary research institute dedicated to building relationships between the university and its surrounding community. Prior to UVA, she served as a professor of law and vice dean and associate dean of academic affairs at the University of Colorado School of Law, where she again co-founded the Legal Colorado Health Equity Project. She's now working with scholars across the George Washington University to establish the Equity Institute initiative at GW with the mission of creating a university-wide research institute to support research and pedagogy that advances racial, ethnic, and socioeconomic equity in the United States and globally. I could go on and on about the service positions that she currently holds amongst CDC, the American Society for Law, Medicine, and Ethics, the Scientific Advisory Council of the Foundation for Opioid Response Efforts. But I'm going to take the time just to pause and say that one of the things that impressed me the most is watching her accept her award this year at ASLME when she won the prestigious J. Healy Teaching Award, which goes to recognize true teachers and mentors in the field. Watching her give that speech really inspired me about the type of mentor that she's clearly been to so many in public health law, and health law. And then getting to watch her speak with our students today, I realized why so many go to her for guidance. Today, she'll be talking to us about her book, Just Health, Treating Structural Racism to Heal America. So please join me in welcoming Dean Dayna Bowen Matthew.
I think it's because I'm on. Yeah. That was the nicest introduction. Thank you so much. I feel so welcome here. I feel so at home here. I got here early yesterday morning. This morning? I got here a little bit ago. And I have people here in Atlanta. So I came and visited my mother-in-law. Went and got some good Southern cooking. Oh my God. And then the welcome here has been so warm. I can't thank you enough to have your vision come to fruition and to be a part of it, Jelaine. Congratulations to you and the planning committee, and thank you for thinking of me. I thank also so many people. Leslie Wolf, my very good friend from many, many years of collaboration and doing as much damage as we can to the status quo. Thank you, Jean Lynn, for the welcome. Professor Collins, so many people that I know. Thank you for coming out. And whenever anybody wants to hear about my book that doesn't have my last name, I'm like, oh, thank you. So I've got a lot of slides, and I talk very fast. I'm from New York. I'm assuming you're going to put on your East Coast roller skates. And I'm going to get to tell you a little bit about treating structural racism empirically. So Marcus was amazing in that I ran in about 15 minutes, and I go, it's all different. I've got a whole set of new slides. And they're all different because of the conversation last night, which was so rich. So I think there's one message I want to leave with you, and that is that health and justice go hand in hand. If you have not got justice, you will not have health. And so the gratitude that I have for being invited here as a lawyer, I hope will extend to influencing your work, to partner with fabulous law school that you have on this campus so that the medical and legal can inform one another in order to improve health outcomes. That's my whole talk. That's everything I have to say. So the punchline first, but in 5 parts because I'm a lawyer. 3 is probably right, but I'm going to go just a little overboard and do 5 things. I'm going to talk really quickly about structural racism just to level set it as a version of structural inequality. And then I want to talk about the role of law because that's where I would like to invite you as empiricists, as scientists, to think about ways in which you could inform the law so that we can make better law and have better solutions. Then I'd like to talk about what that looks like on the ground and maybe invite your participation and comment. So structural inequality. This is the generic version. So I live in DC. My office is right across the street from the World Bank. And the World Bank has a Gini index, which I know a lot of you know a lot about. So I won't spend a lot of time on it except to point out a couple of things from this graph of the OECD index from 2000 to 2017. So first, you know the index divides populations into quintiles and measures the distance between the top and bottom quintile from income in this particular version. And so it is a measure in colloquial terms of the difference between the haves and the have-nots in a country. Secondly, look at the country that's to the far left. Of the OECD countries, the United States is the most inequitable country, right? But when you have an index like this, you can array it as against an outcome measure. Wilson and Pickett have arrayed it here on the x-axis and then measured it against, or cross-tabulated it against, an index of health and social outcomes. So their index of health and social outcomes includes 10 measures, 10 variables, many health, disease, mortality rates due to lung cancer, heart disease, so forth. Some are social outcomes, educational disparities. And what they find when they array those indices, the index of health and social outcomes along the y-axis from better on the bottom to worse outcomes against the Gini index from the left to low disparities to high is a very predictable, easily replicatable relationship. It's a positive relationship. So the more inequitable a society is, the worse its health and social outcomes. So I want to posit to you that structural racism is a racialized version of that structural inequality. So when I talk about structural racism, if you've looked at, as so many of you were kind to, my book, I introduce it or I humanize it by introducing my parents. This is May and Vincent Bowen. They are 47 and 48 here in this picture. And a year later, my father is dead. And he's not dead because he's particularly unhealthy. Like, he is slightly overweight. But he's dead because, I posit, he lived under the burden of structural racism, right? And for those of you, again, who have looked at the book, I won't belabor it. But one of the key points that's captured in the Gini Index for countries that I'd like to specifically apply to my father is the fact that he worked with my mother 5 jobs between them, and had to do so because not a single one of those jobs paid a living wage, right? That's a structural problem that plagues not just my father, but everybody that lived in the South Bronx and looked like him growing up, right? That's the structural nature of the problem. So he'd go to work in the morning, 9 to 5, wearing a suit, very proud of him. He was able to do that because he went to school at night, got his BA, and in the South Bronx, the number of men that went to work wearing a suit was a limited number of men. So I was really proud when he would walk up the street from home to the number 4 train and take it down to the Bowery Savings Bank, and he was a real estate appraiser, 9 to 5. Come back home 5:30, sit down for dinner, change his clothes, take a nap, and then put on a pair of overalls and walk to the same subway and work another 8 hours driving it, right? Add to that 2 jobs on the weekend, and my mother had a job, and that's how I get to stand here, right? But that's also how he dies 1 year after this picture is taken, right? Now, why did he have to work those jobs? Well, for one thing, if he had not, I would have gone to PS 123. So my elementary school was PS 93, and my middle school would have been PS 123. If you look up PS 123 today, you will find that it's now a magnet school after being closed for 5 years for violence and underperformance. So that would have been my school, and I would not have been here. Every single man in my neighborhood who had a kid that they wanted to get a good education, they had to get them out of the South Bronx. How do you do that? You have to work 4 jobs, right? Now, where we live is also called Cancer Alley, or Asthma Alley, excuse me. And that was because when I was going to PS 93, I was crossing over 3 interstate highways every day in order to get there. So you get the drift, right? Where I lived and the people that were consigned to the neighborhood in the South Bronx where I live, my father and my mother are not unique. They are exposed to different air. They drink different water. They eat different foods. By the time I moved from the South Bronx school that I would have gone to the beautiful Riverdale school. Anybody from New York, Riverdale? Riverdale, beautiful, bucolic, gorgeous, rolling hills, supermarkets just a beautiful place to live, right? And nobody there crossed highways to get to school. Nobody there had trash transfer stations located in proximity to their high schools. Nobody there had to leave their neighborhood in order to go to another neighborhood, and nobody's dad worked 4 jobs, as far as I could tell, right? So the fact that my father and mother's story is not unique, and the fact that it led to their early death, I have outlived my mother. Now, I'm not going to tell you my age, but I'm older than she was when she died. It's not unusual. You know the data better than I do. You know the life expectancies, and you know the epidemiology, but it is structural racism, the residential segregation, that determine the air they breathe, the water they drink, the food they ate, the schools their kids could go to, the incomes they experienced, that I contend is a health hazard. Now, the other way I show this to audiences far less sophisticated than you, so I won't belabor this, is I show this picture of Flight 1549. I have to really credit one of your colleagues, Tom Leviste, with giving me this idea. 1549, the movie Sully, 155 souls on board, hit a gaggle of geese, they land on the Hudson River, it's January, you cannot live in the Hudson River in January for very long. But if you look here, there are 2 groups of people on this slide, right? They're all out. Big group in the back is standing on the wing of the plane. The plane is going down, so the water's lapping up around their ankles. Small group in the front of the plane are sitting in rafts. They got on in first class, and so they have a life raft, they have life jackets, they have rations, and I always say this, so they don't have to eat each other as soon as the people on the other raft. Because they are in a different place in the plane, right? And you know this is place matters. This is the mechanism by which I explain. My parents were living on the back of the plane, and that's the largest group of people now. There's one more picture I'm not going to show you because I'm trying to get to the real point of my conversation with you today. And that is a picture of a bunch of dead fish on the ocean, on the seashore. Right? And you've seen this if you know the groundwater theory of racialized or structural racism, racialized inequality, right? You're walking along the beach, you see one fish on the sand, and it's dead, and you say, oh my, something happened to that fish. Something's wrong with that fish. If you see the picture that I would have showed you if I wasn't rushing through this, and it's hundreds of fish flown on the beach, and all the fish look the same, right? They all look like my mother and father. No matter what the outcome measure is, you say something's not wrong with the fish, something's wrong with the ocean. And that's what I'm asking you to think of structural racism as. You know this. You know the data from the COVID-19 pandemic, which is not over. You know the racialization of hospitalizations, case incidents, and deaths. And you know it's because of where people live and where they work and where they play. And you know that's true in cities as well as it is in rural neighborhoods as well. So what I want to focus on is the role of law in creating structural racism. And my objective is to convince you that you, as public health scientists, will amplify your work and effectiveness if you appreciate and engage with the role of law. Right? So I feel as though I should use the privilege and the joy of being invited here today to get you to invite more lawyers, right? And to collaborate with more lawyers. Because the law does three things. So structural racism I define as a system that not only hierarchically distributes people, defining their value and worth. Said another way, it institutionalizes white supremacy. Right? And then secondly, takes that institutionalization of white supremacy and allocates all of society's resources, right? All of its power, all of its resources. And that is where law comes in. So at the bottom of this is the paradigm that I could spend the rest of the time talking about, right? We spend a lot of time when we talk about racism on the top of this conceptual model. We spend a lot of time talking about individual prejudice. And we get stuck there because nobody's a racist. I'm not a racist, you're not a racist, and nobody wants to be a racist. And so they stop there and they think, okay, I'm fine. Much of the study, I'm going to be a little bit provocative, much of the study that you do right now lets people off the hook. Right? Because your stratifications by race allow them to think that the only anti or negative interaction that they can have with race is race qua race, right? Not racism, but race qua race, race as race. And if I'm not guilty of interpersonal animosity towards race, then I'm not part of the problem. I don't have to seek part of the problem in my solutions. But you move down, just the way you would Tom Frieden's health impact pyramid, to the bottom of this structure, and here you find the institutionalized, the structural sources of racism. And I am really focused on what law does down at the bottom of the pyramid. It does three things. I'll go through them quickly. It legalizes dehumanization. It makes it okay to think of people as not human, or to treat them as not human. Secondly, it legalizes inequality. We think we have this thing called the 14th Amendment that constitutionally implores us to legalize equality. Actually, we do not. The fact is that we have turned the law on its head, in my view, so that we do more to legalize inequality than equality itself. And that is through a third mechanism, which is unequal protection of the laws. I'll demonstrate it really quickly. So legalized dehumanization. Here, again, is someplace I could spend a lot of time, because dehumanization is something that gives us justification not only for the way that we treat people, but social psychologists tells us it informs our political viewpoints and what kind of laws we will tolerate, right? We will justify the utter reversal of the Voting Rights Act, the signature piece of legislation. We will explain that our laws concerning unreasonable use of force by police officers are warranted because we have subconsciously, or maybe consciously, perceived as a population as less human than, not possessing the same human qualities. Now, we know this from slavery, right? That's an easy example of dehumanization. You sell people by the pound, you consider them property, that dehumanizes them. They are not people like me because I would never do this to me or my child, and so they're easy. We know this from the stories of how the law would allow slave ships to recover property, insurance, for people they deliberately threw overboard to lighten the load in a storm. and then go back to court and get the insurance right. We know that. But we see it today, right? In Jackson, Mississippi, and Flint, Michigan, where the thing we need most to live as humans, water, is denied people, and we think it's okay, right? There's somehow a acceptance that those beings don't need water like we need it. It's an acceptance that this took a whole lot of judicial machinery to prove as culpable, right? Second thing, what does the law do? It legalizes inequality. Well, the common example is familiar to you, the Jim Crow era, when laws in every category, I'm fascinated by this. We were building a database of the laws of Jim Crow in each of the 50 states in order to create an index of structural racism by law, right? And this was one of the graphs we put together, or we started with, I should say, where we were looking at the intensity. How many laws did each of the 50 states have? Were you just a state that adopted a Jim Crow law that segregated hospitals and schools? Or were you a state so committed that circuses and bathrooms and indeed cemeteries? So the volume of Jim Crow's laws was one part of the measure. Secondly, the early adopters. How early were you to adopt Jim Crow laws? The extent of your law, how long was it before you repealed laws? So this was an index we were developing, and then taking that index and looking at the concentration. I give that to you as an idea. The database is built, but we haven't really got the index structured. Help, right? Because the indices right now that measure structural racism are incomplete, in my view. We can talk about it in Q&A. But the inequality of our laws is pervasive. I do this with young people in my class because they know about the use of marijuana, right? Intellectually, at least, right? So on the left is a graph that shows black and white use of marijuana from a period from about 2000 to 2019, right? And this data is actually too hard to come by. But it shows that the height of the black and white bars pretty close. On the right, of course, is the disparity for possession arrests between blacks and whites for possession of marijuana. Right? The bars are wide apart. We legalized inequality in the way that we enforced our drug laws. This is just one tip of the iceberg example, but you get the point. And I did something very wrong there. Let's see. So law is the mechanism by which we dehumanize. Law is the mechanism by which we install inequality. Law is the institution that makes it possible, hear me on this point, for each and every one of the social determinants of health to be maldistributed. Right? Housing, education, pollution, all are maldistributed by law. But that also means that law is the key mechanism for repairing it. Right? So I applaud and consume just your work and your literature as public health scientists is full of observations, correlations, and even solutions that I encourage you to partner with lawyers to actually implement, to partner with legal experts. I think it will also change the way that you ask and answer your questions, your research questions, if you're working with policy advocates who understand what it means to translate your work into action through law. So what does it look like to empirically treat structural racism, right? I'm medicalizing this idea of structural racism. I'm a very, very good friend. I don't know where Aaron Peace Brown is here. And John Kahn and I have argued over so many meals about whether I get to do this. And I'm still doing it, although he's got some really good points. I'm medicalizing the idea of structural racism, and I'm saying it needs treatment. You have to treat it, right? So what do? We need to partner. We, lawyers, legal experts, have to partner with scientists in order to really eradicate structural racism. So where do we start? You could start anywhere. You can pick anything to study. And I've been here for less than 24 hours, and there are people here studying domestic violence and alcohol, and I mean, just so many different things. Just pick something. There is inequality in every single structure in the United States of America, right? Whatever you're picking needs equalizing. It needs to reverse dehumanization. It needs equal protection of the laws. So I'm going to show you two and just say the data is so sparse. Causal data, understanding the impact of laws that have been passed, figuring out what works and what doesn't work. We don't have the empirical basis to do it. And as a result, if you're sitting like, okay, I sit on Capitol Hill for 1 year of my life. I don't ever want to go back there. But I spent a year in Capitol Hill, as you heard in the introduction, and we had this thing that made me feel very wrapped in the flag, quite honestly. And that was, you can't quite do it today, but anybody could walk into the Hart Senate building where I was working. And they could say, my senator, I was working for the senator from Michigan, my senator needs to hear what I have to say. And they could literally walk up the stairs, knock on the door, and they would get at least an audience with me, the health policy fellow, at least with me. And then every week I'd have to report to the senator, this is what your constituent, John Jones, or Jane Jones, said about the problem they have in your jurisdiction, right? What a country, right? You could speak to power. But the fact is, if you're speaking to power, and there is nothing that power has the evidence to act on, we found ourselves in the middle of the Flint water crisis with no data to tell us that we could go and create a constituency that could implore Congress to allocate money to change lead pipes. Now that has just been done. What? I don't remember how many years later. 6 years later? I think people in Jackson, Mississippi are still drinking water out of plastic bottles. It is not possible to do evidence-based lawmaking without the evidence, right? So if you want to combat the kind of prejudice that started like this, you can't still treat it as though it's acting like this. You have to use the model that you, as social scientists, are developing, and then begin to build an evidentiary basis that tells us exactly to what extent will I change health outcomes, infant mortality, life expectancy, whatever you want to try and use as a dependent variable. But what difference will it make if I change the dissimilarity index? I don't know. And is that a better use of my legislative effort than, say, changing the community centers that will build social capital? I don't know. I don't know, although this model is very intriguing and informative. I don't know where to start if I'm a legislator because I don't have the evidentiary basis that tells me what next should I be working on if I would like to change segregation in order to impact health outcomes. I know that poor housing creates and must be causally connected to poor health outcomes. For any number of these 4 reasons, pick one. I pick substandard quality, and I can't find the data to update this graph past 2001. Now, maybe you know where it is, and you're just going to send me an email, and I'll have a better slide for my next presentation. But I couldn't figure out what I know to be true, and that is the disproportionate prevalence. The fish on the ocean are all black and brown, low-income whites, that are living in substandard housing. Now, I can draw a heat map, right? And this is New York City, where I was born and raised. So this is a heat map of racial concentration, right? So the green dots are white people. They're all in Manhattan, right? I'm sorry, that was a little crass. Higher concentration in Manhattan, right? Black people are living predominantly in Brooklyn. Latinos living predominantly in the Bronx. And where I lived in the South Bronx here, if you look at that next to a map of housing code violations, right? Where is there no electricity, no indoor plumbing, right? Where's the heat? working less than it ought to during the winter, right? I can see that in Manhattan, where all these green dots are, I don't have very many housing code violations, right? But down here in Brooklyn, where the Black and Latino people live here in the Bronx, I have a lot of housing code violations, okay? So if you want to talk to me about what I should do about that, because right now, I walk into New York City and I show people that and they go, oh, what a problem. That is a terrible problem, right? But I think it would be a powerful combination if your data about the impact of housing code violations, not poor heat, housing code violations, because that I can sink my teeth into that as a legislator. I can do something about that, right? And I can talk about how much money it saves. I can talk about how many work hours it saves once I have the evidentiary basis. The data that I need, if we talked about what it is that really and honestly communities want answers to, not just us as academics, but if you talk to communities, they're like, I don't know what you study, I don't know what your research is, but I know one thing, I don't have heat. I know my baby's cold. And if you could figure out how to answer that question, that would be useful. So just more of the same, like where's the prevalence of asthma? Where the housing code violations are. That's easy, right? Where is obesity concentrated? Where food insecurity exists, right? So if you could tell me something about the difference that changing zoning laws in order to incentivize the location of food that is healthy in neighborhoods. Flint, Michigan, not one single supermarket chain, not one in Flint in 2016 during the crisis. So many things, income differentials. You could talk to me, I'll be a little bit provocative. You could talk to me about what difference reparations would make. What would it mean if you equalized income? Tell you what, don't you worry about buying me better food and giving me access to your food bank. I'll tell you what, don't you worry about doing anything except for paying me a living wage so that my dad could work 1 instead of 4 jobs. That's all I ask you to do. Pay me a living wage, and I'll buy my own food. I'll educate my own child. Maybe that's the intervention with the most bang for the buck. And reparations is not just a philosophical argument or a discussion about the transaction between who was a slave owner and who was not a slave owner, right? And what the present value of slave transfer. Just tell me, if you pay me a living wage, I will be more healthy, cost you less. And all the other social determinants of health will follow. That's my instinct, but I don't know if I'm right. Last one, equalizing educational attainment. I love this one because this is still where we are in the law, thinking about, here's the problem. Well, the Supreme Court's about to do you and me a favor. They're about to tell you that affirmative action is dead. I am being very facetious when I say that is a favor. That is hardly a favor. But affirmative action law, to be fair, has not progressed since this model of discrimination. And today, the discrimination in educational attainment, we know this is one of the most beautiful conceptual designs. It's by Hogue, H-O-G-U-E. I think it's Anne Hogue. One of the most beautiful conceptual designs of where the connection between educational attainment and poor health outcomes lives, right? So I understand the model. There is so little data to explain all 3 of these pathways and mechanisms. So here I am, a really good guy when it comes to legislating in my local school board. I am a good guy, and I don't know whether I should be legislating about health knowledge and literacy. Is that what really is going to make the difference? But I've got this other guy screaming in my ear that the real problem is critical race theory, right? And so that's what I move on, because there are too few, I think, empiricists speaking to the local government decision makers about how many interventions could change this connection between educational attainment and the lack thereof in these 3 areas and poor health outcomes, right? Should I be working on the psychosocial network? Should I be working on work as an outcome? Should I be doing job training programs in order to improve health outcomes? So many questions, so many possible interventions. I'm teaching public health law right now to a bunch of law students all by themselves. There are no public health students in the room. That's a mistake. Nevertheless, the models I am talking to them about is how to choose among all of the political and legal levers that they can pull. There are theories abounding as to which of the legal levers they should pull. But I've only sent them out half-equipped, because what they're going to base their polls on is their gut instinct. Who's yelling the loudest? I think you get the point. Discrimination today takes the form of a very sick funding system. Educational disparity takes the form of a $23 billion with a B dollar gap between the funding in white school districts and predominantly Latino and black school districts. We haven't even begun to do the data on Native American school districts. We don't know anything about the data with respect to so many other marginalized populations. Transgender populations and their school attainment, we don't know, really. Right? And I don't know what to do about disparities in suspensions that begin at age 3, and what the difference is in disparities in expulsion, and what happens when you take a kid from middle school who's white and put them in treatment, and take a kid from middle school who's black and put them in juvie from a health standpoint. But I know it's happening. Here are 6 different measures of discipline disparity. It is my view that it is time to stop describing the problem. This is so overwhelming a body of evidence that it doesn't matter if we're talking in-school or out-of-school suspensions, corporal punishment, that red bar that defines the overrepresented group as black is so pronounced on this, I don't need any more data on this. I need the data that connects me to solutions at this point. Same with access to a full range of science courses. Same with access. So here's the thing. We know education is connected to health outcomes. So whoever did this, and I can't remember who the study is, if you're interested in it, it's a fabulous study, right? But it looks at non-Hispanics, whites, blacks, male and female, and what their risk of death is at different levels of education. Precipitous drop in the risk of death just by graduating high school, right? So if we really are serious about the epidemiology of extending life expectancy, maybe the real bang for the buck is high school GED programs. Maybe that's where the intervention is. So I'm going to save you the section on criminal justice just to remind you that this is a disparity, that it permeates the entire criminal justice system, and give you some idea of episodic examples of success where data meets interventions in housing, right? There are large healthcare entities, United Healthcare. After the Medicaid data showed that homelessness was a key driver in repeat visits to emergency rooms and repeat encounters with the criminal justice system for dumb stuff, right? United Healthcare invested in stable housing, affordable housing projects. Now, there's a lot of debate about whether hospitals should be in the business of creating housing projects, but you want to know what? The housing investment was more than paid off by the decrease in emergency room use, and the improvement in health outcomes. When the data in Brockton explained the correlation between reducing incidence of, I'm going to say this wrong if I don't get it right, you'll correct me, but what's it called when you have a really high A1C and you're a diabetic? Keto? Thank you. In Brockton, Massachusetts, the city government created a social impact bond using laws that allowed a Cape Verdean grocer to co-locate with a federally qualified health clinic. The bond was necessary so that they could buy land together. The zoning exceptions were required in order to make it possible for them to create a test kitchen or a training kitchen, which was also a clinical examination room. So they could take groups of patients, up to 8 patients, into this clinical exam room, do their sort of basic well-patient checkup while they were talking about recipes that improve diabetes health outcomes. Hand a food prescription to the patients, and then walk them across the threshold to the grocery store where they could get culturally appropriate food. And again, the data that we have is really rudimentary at this point, but we think that this is reducing mortality and morbidity due to diabetes among this Cape Verdean population. More of the same, please, right? Violence prevention, we've seen it in Wisconsin. This is one of my favorite programs called AGIMA, which is a multidisciplinary violence program, prevention and treatment. This one's super cheap because the intervention that was empirically supported was mentoring, right? And so instead of sending gang members between the ages of 7 and 18 who came in with gunshot stab wounds and other evidence of gang activity back to the streets, they sent them into mentoring programs. And again, the data is very rudimentary, but it looks like, oh my gosh, the recidivism rate is minuscule compared to those who are outside of the program. So the solutions used to look like this, right? It used to be that this is what we had to do in order to make justice and objective for all and to bring equality into reality. But this was also part of the solution, right? This was part of the quiet revolution when physicians, clinicians, nurses, and I dare say public health specialists marched. And maybe marching's not your thing, but maybe it is if I get 1 or 2 of you to march. That's not a bad outcome. Maybe litigation is not your thing, but I'm going to tell you, we would not have had a Civil Rights Act of 1964 if medical doctors, 2 of them, 3 dentists and 3 patients hadn't brought that case that is basically responsible not only for desegregation in hospitals across the country, but also for influencing Congress to pass the Civil Rights Act of 1964. So if litigation is your thing, here's your stop. This is where you get off, and this is where you work. But since health is a byproduct of justice, I end with this picture of redwood trees. Because although I'm not an arborist or a botanist, each one looks like it stands alone, but it doesn't. Underground, they're all connected by roots. And I'm just trying to build more connections between our disciplines in order to eradicate structural racism. Thank you.
We do have time for questions. I will say that Dean Matthew has to be like literally getting in the car at exactly 3 o'clock. But I'd like to open up the floor for about 15 minutes for questions. Do we have a microphone? Lillian can help run the microphone. So I'll take prerogative since I'm standing on the stage here, but I would, I would really love to hear your thoughts on how, and I say this from a biased position as a JD, so thank you for advocating for more of us. I did tell the committee that if they weren't careful, we would end up with all JDs coming to give our talks. But how do public health practitioners and researchers learn to communicate clearly with JDs and vice versa?
Yeah, the thing that I think is awesome about your question is that you're asking it in a setting where there's a really important change that can be made right here at GSU. I'm trying to make it everywhere I go, and that is to educate the 2 disciplines together. So there should be interprofessional education among JDs and public health students, Masters of Public Health students, Doctor of Public Health students. Because beginning the dialogue when you're in the pre-professional phase not only helps with the language, helps with the understanding of each other's disciplines, but it really changes what are sort of very different paradigms about problem solving, and opens up those paradigms, right? When health scientists look at a problem, typhoid fever, they're like, oh, let's look at the population and let's figure out where the death rates are. Let's keep the data. Let's do the epidemiology. You have to do that. When lawyers look, we're like, I tell you what, we'll find people and they'll figure out where it comes from, right? But those two disciplines don't match. The solutions don't work. Finding really does not work. It does not work alone. So if you start with pre-professional education, I think that would work.
Thank you. Okay, I'm going to open it up. I know that somebody in here has to have a question.
Or not.
Can you wait for the mic? Sorry, we have people on Vimeo who are joining us virtually, so I want to make sure they
Testing, okay. So you alluded to kind of correct me if I'm wrong, but addressing poverty levels or some sort of minimum wage. You had a sneaking suspicion that that would be kind of like a first priority. When you had that little thing, that was.
I think you're right.
Yeah,
Yeah.
I've kind of always thought that, but I kind of want to go into like maybe the economic side of it too. In your book, you mentioned opportunity cost with crime and whatnot, and I was wondering if you could maybe elaborate a little bit on that.
Okay, so if I don't hit your question exactly, interrupt me and tell me, because I'm thinking I understand where you're coming from. Some of the data that's really helpful is connected to the opioid crisis, where we see a reduction in the number of opioid overdose deaths as we see an increase in not fancy white-collar jobs, but low-wage, low professional level jobs have a really, I don't remember the beta coefficient, but a really profound impact on the incidence of overdose deaths, right? So that says to me two things. One that's, in my view, obvious. People who have despair do things out of despair, and they suffer deaths of despair, right? No matter what color they are or where they live. And two, interventions that are economic save lives, right? You give people jobs, you give them a living wage. I don't know, my father might be alive today. He made a living wage. So the opportunity cost that you're talking about, right? I think what you're saying is how much we lose in personal capital because people are lying in the gutter, unable to find a future, unable to find a job, unable to get their lives on track because there are not jobs that will give them hope to get out of this despair. That's something economists are very good at quantifying. There's a variable, I can't remember exactly what it is, but lives lost, quality of life lost, something like that. And so it's data that we could use to improve not only a reduction, or to achieve not only a reduction in opioid deaths, but improve a lot of other health outcomes too.
Harry and then Collins. Right here, sorry.
So thank you very much for your incredible work and your persistence. You know, it's one thing to just publish one book and then say, yeah, I've done it, and now I'm just going to lay back and enjoy it. This is number 2 for you, and you've been in this for a long time, so really appreciate you and your work. I have a couple questions for you, but the one I'll ask is, I worry about, so there's sometimes a challenge between doctors and lawyers. It's not always a comfortable relationship. I would say there's a similar discomfort between public health folks and economists.
Oh, okay.
And economists, because there's a sense among economists that, you know, the best way to measure the importance of an intervention or a policy change or an outcome is return on investment.
Yeah.
And everything that's important, as we all understand, does not have a economic return on investment. In fact, when you look at CBO studies, which I know you have, and their 10-year timeline, most of prevention doesn't show return on investment in 10 years, but it does in 30, and it does in 50. So it does by the time you get to be in your 40s or 50s, but it may not by the time you're 3 or 5 or 10. So tell me how we can think about framing, recognizing the value in a policy space of economic return on investment, but not collectively shooting ourselves in the foot by leaning into those kinds of metrics which can undermine what we're trying to achieve.
It's really a nice question. So I think I'm going to sidestep it a little bit by telling you this. My first grandchild was born about 3 months ago, which makes me pretty old. And one of the things that's really wonderful about getting old is you stop trying to convince everybody, right? I don't have to tell I don't have to win all the hearts and minds, right? There are health economists who understand how to do an ROI in the settings where health outcomes are the dependent variable that you're trying to work on. And the only place I've really encountered this literature is in medical legal partnerships. Medical legal partnerships suffered for a very long time a dearth of economic information or data that told health centers that the investment in putting a lawyer, a social worker, and a paralegal on their staff and billing, they couldn't bill for it. There's no Medicaid code for the lawyer, right? But that the return on that investment would actually reduce emergency room use. And we had a very hard time proving it until we found a few health economists who were willing to do things like, well, you can't do a random clinical trial, so we'll use propensity matching instead. And brought those economic tools to bear on the question of whether or not you were actually seeing a correlation between the investment in a medical legal partnership. And there's lots more data now by economists. And we only need a couple of the economists, maybe educate them as well in this interprofessional education model. And you only need a couple who understand how to speak that language. And a couple of political scientists who understand how to speak that language, a couple of lawyers who understand how to speak that language. So it doesn't have to be that we convince all of the economists. Because I'll tell you what, you won't convince all of the legislators. You won't convince all of the city council members. You won't convince all the members of the Supreme Court. But you only have to convince a majority. You have enough tools to work with, I think, with economists who do get it and do get the ROI model, the return on investment model that would communicate effectiveness and impact.
All right, I think we're going to go with Collins, and this will be our last question.
Thank you so much for this powerful presentation, very, very insightful, and it's something to think about more in terms of we funding agency and what we do. There's this codependency between the discipline that produce the areas you feel are limited and the agency we rely on to support our work and gain the validation that is recognized in the academy. I wonder if you've thought of, you had the opportunity to look into addressing how funders create what some of them also call funders-induced pathology, where they set priority and everybody gravitate. Yeah.
You know, funder just cut your mic off. No, I haven't thought about that, but I think, I know you're right. And this, I'll end on suggesting, is a reason to favor community-engaged research over every other form of research, because you choose, instead of asking and answering questions that will suffice for the next funding solicitation, or that will draw the next research dollar, or get you with a publication that will be your promotion, your step to promotion. You ask and answer questions that community members really need answered, right? And you take this precious resource that we have in higher education of creating new knowledge, and you create the knowledge that communities need created to solve the problems that really need to be solved, to provide data for community activists who are, ready to go down and march down to their state legislatures and give the testimony and the narratives and make the case, but don't have the data that would give heft to their arguments. If you partner with community members to understand the questions that they need asked and answered and the problems that they see as highest priority, then it won't be very long, I don't think, before the knowledge that you produce has impact and funders follow you. So sometimes it has to be internally funded. The Equity Center and the Colorado Health Equity Project, even the one, well, no, the two projects that we talked about earlier at the University of Colorado and the University of Virginia, we started those with internal funding as a proof of concept, put out the data, and then funders came after. Right? So now this time around, I said, I did it twice, and funders have been more forthcoming. But so I think it's a question of deciding not to let the tail wag the dog, but to, as Brian Stevenson says, get proximate to the problem you're trying to solve and the people you're trying to help, and let them tell you what they need.
So I'll just close and say thank you so much. I do want to thank Dean Lynn for making his initial investment in this program. It is because of his idea to provide faculty innovation funds that you are here. So just want to acknowledge that and just say thank you so much for serving as our first speaker. I can't think of anybody else who would have done such a fabulous job. And just thank you all for coming today.
Great thing that you started. Thank you for having me.
And not to sound like a flight stewardess, but she is trying to make like a really tight flight this afternoon. So we're going to let her go ahead and catch that flight this afternoon. She disappeared.